Welcome to Learn Ophthalmology with Aahan. In this tutorial, we'll take a layered look at the anatomy of the eye, not just for academic understanding, but with relevance to clinical and surgical ophthalmology. The eyeball is a slightly irregular sphere, approximately 24 millimeters in diameter antero-posteriorly. It's divided into anterior and posterior segments separated by the lens plane. The eye has three concentric coats. First, the fibrous tunic, which includes the sclera and cornea, providing structural support and refractive power. Second, the vascular tunic or uvea, consisting of the choroid, ciliary body, and iris, essential for nourishment and accommodation. And finally, the neural tunic, the retina, which is the functional sensory layer. The cornea is avascular, transparent, and contributes about 2/3 of the eye's total refractive power. It has 5 layers, the most clinically relevant being Bowman's layer, stroma, which makes up 90% of its thickness, Descemet's membrane, and the endothelium. The anterior chamber lies between the cornea and iris and is filled with aqueous humor, which is critical for intraocular pressure regulation. Posterior to the iris lies the posterior chamber, which is bounded by the ciliary processes. The lens is a biconvex avascular structure that is suspended by zonules from the ciliary body. Accommodation is mediated by the contraction of the ciliary muscle, which reduces zonular tension and allows the lens to become more spherical. This function, however, deteriorates with age, leading to presbyopia. The uvea has 3 parts: the iris, which acts as a diaphragm regulating light entry, the ciliary body, which is involved in aqueous production and accommodation, and the choroid, which is highly vascular and supplies the outer retina. Inflammation of the uveal tract, known as uveitis, is clinically categorized based on the anatomical location. The retina has 10 histological layers, but clinically we divide it into 3 main zones. First, the posterior pole, which includes the macular and optic disc. Next, the mid-periphery, extending up to the vortex vein ampullae. And finally, the far periphery, which is prone to degenerations like lattice or retinal tears. Now, let's talk a bit about the macula. It has a high cone density, which is absolutely critical for central vision. The fovea centralis, located within the macula, is the thinnest point of the retina, featuring a displacement of inner retinal layers. The optic nerve begins at the optic disc, passes through the lamina cribrosa, and continues intracranially to form the optic chiasma. Here, nasal fibers decussate, leading to the characteristic visual field patterns in lesions. Some anatomical details every postgraduate must integrate into clinical work. A shallow anterior chamber increases angle closure risk. Loss of endothelial cells post-cataract surgery can cause pseudophakic bullous keratopathy. Zonular dialysis leads to phacodenesis or lens subluxation. Choroidal detachments may occur post-filtration surgery due to hypotony. Peripheral retinal landmarks like ora serrata are critical during scleral buckling or vitrectomy. To summarize, understanding ocular anatomy isn't just foundational. It shapes the way we diagnose, plan procedures, and predict outcomes. Thank you for watching this postgraduate review from Learn Ophthalmology with Aahan. Stay tuned for our upcoming tutorials on applied optics, slit lamp mastery, and surgical decision-making.